Hello, my name is Tana Brooks. I am an emergency department charge nurse and a nurse consultant for the California Bridge program. I would like to thank you for joining me today as we discuss the nursing management of patients with opioid use disorder and how we can drive best practice care for our patients. I have nothing to disclose and have no actual or potential conflict of interest in relation to this presentation. At the end of this module, you will be able to describe the benefits associated with medication for addiction treatment, increase knowledge of the medications that are used to treat opioid use disorder and how they work, develop and implement a nursing care plan associated with acute opioid withdrawal, distinguish when to advocate for an immediate start versus a home start of buprenorphine, and understand the ethical implications and stigma associated with OUD and its treatment. All right, let's jump in. Addiction is not a moral failing. It is a chronic disease that requires medical treatment. Let's talk a little bit more about how this is a chronic disease. What we are seeing is that patients are much more successful at engaging in treatment when substance use disorders are approached from a long-term care perspective. This translates to improved treatment outcomes and quality of life, decreased mortality rates, and decreased disease transmission and violent crimes. So just like patients with diabetes or hypertension need long-term chronic care, patients with substance use disorder, and more specifically opioid use disorder, need chronic care. We would never tell a person with diabetes who presents to the ED with hyperglycemia, well, since you have not been managing your blood sugar well based on your labs, we are not going to be giving you more insulin today. That would be inappropriate medical management. This is exactly how we should feel about patients who use drugs when they check into the ED in withdrawal. It is absolutely inappropriate to deny them the care they need for their disorder when they arrive in acute crisis. Let's touch on the background of substance use and how it impacts the healthcare system. We are all familiar with the significant increase in drug-related overdose deaths over the last 40 years or so. Look at how steep the curve is on the increase in drug-related overdose deaths, and specifically those related to opioids. You can see that overdose deaths in 2017 actually surpassed that of peak car crash deaths. I would like for you to consider everything that we have done to improve safety and decrease mortality within the automotive industry. Seatbelts, airbags, speed limits. What are we doing to prevent and decrease these mortalities related to OUD? In addition to the rise in mortalities related to opioid use disorder, we are seeing a resulting impact on the healthcare system. Both inpatient and ED are having similar increases in visits related to opioid use disorder. Let's discuss MAT and how it can benefit our patients. This is a summary of the various medications we use for addiction treatment. Methadone is a full agonist. It is utilized in highly structured and supervised settings, which helps to mitigate diversion risk. Methadone has been shown to be effective for those who have failed treatment with partial agonists or antagonists. Buprenorphine is a partial agonist. This is the medication that our discussion will focus on today. It is a very safe medication while still being highly effective. It is also convenient as it can be given in office-based settings. Naltrexone is an antagonist. The main benefit to this medication is that it is a treatment option for those who prefer to avoid all opioids. It has no addictive potential or diversion risk, but patients have a higher overdose risk due to their loss of tolerance. This is how opioid agonist therapy works. When a person uses an opioid for the first time, they experience euphoria and then return to feeling normal. Each subsequent use then causes that euphoric feeling or high again. Then they return to feeling normal. Then at some point, they build up a tolerance and a physical dependence to the drug. Now they experience withdrawal symptoms when between uses and are using just to feel normal. Our goal with MAT is to help them feel normal again consistently, and we are seeing high success rates with this treatment approach. Let's discuss buprenorphine, or as we like to call it, bup, in a little bit more detail. This is a partial opioid agonist that has a very high affinity to the opioid or mu receptor. This means that it binds more tightly to the receptors than the full agonists, such as heroin, methadone, or fentanyl. It will actually bump the full agonist off the receptor. Because of this property, it is important to time the induction of treatment correctly in order to avoid causing a precipitated withdrawal. We definitely do not want to start someone on a treatment that is supposed to make them feel better, only to unintentionally throw them into severe withdrawal. Another benefit of this high affinity is that subsequent use of full agonists do not have the same effect as they would without bup on board, which significantly decreases overdose risk. A person who uses heroin with bup on board is much safer than one who does not. Bup also has a ceiling effect on both respiratory depression and feelings of euphoria, which makes it very safe and effective. What we have seen with bup, even at higher doses, is that respiratory rate and oxygen saturation do not drop below safe levels. Additionally, because bup does not cause the euphoria or high that the full agonists do, it has a low risk for diversion and abuse. Buprenorphine is an excellent pain medication. When it is used as an analgesic, it will generally be prescribed with TID dosing, as opposed to the daily dosing that is typical for treating addiction. Bup is commonly administered as a buccal strip or sublingual tablet. You may see it in combination with naloxone or as a monoproduct. Now you may be asking yourself, why is it formulated in combination with naloxone or Narcan? That is a great question. The naloxone component actually functions as a deterrent that is inert when the tablet is taken sublingually, but becomes active if the tablet is injected or snorted. Another one of the reasons why this medication is so safe. We will not be discussing in detail the other formulations of bup today, but know that it also comes in IV form, as an extended release sub-Q injection, which is administered monthly, and as a patch. Bup patches are prescribed for chronic pain management and should not be administered for treatment of OUD. I would like to circle back to the ceiling effect of bup. Sharon Walsh actually did a study where participants were given varying doses of bup, and then she asked them at specific time intervals, how much do you feel the drug? What she found confirmed the ceiling effect of bup. As you can see, the 8, 16, and 32 milligram doses all followed a similar curve which flattened out at about the same point. Basically, what was seen with the higher doses was just a longer duration of action and not euphoria. This can be helpful to know when a patient is started on treatment but does not have a follow-up appointment for greater than, say, 24 hours. A higher dose could be considered to cover them until they make it to that appointment. Let's look at another study. This looked at ED patients who were identified with opioid dependence. The participants were separated into 3 groups. One group received referral to treatment. The next received a brief intervention and referral to treatment. And the last group received a brief intervention, treatment with bup, and referral to treatment. They found that patients are more successful at engaging in treatment when they are started on appropriate medication in the ED. Another finding in this study was that all of the groups reported a decreased frequency of illicit opioid use. However, patients in the treatment group reported much less use than the other groups. This is exactly why we need to make MAT accessible for all patients. It is reducing harm and risk for overdose. Many patients and clinicians as well want to know, how long will bup be needed? Now, what would you tell a patient who asked you, how long will I be on insulin for my diabetes or lisinopril for my hypertension? The answer really is, as long as you need it. Some patients may be on it the rest of their lives, and others may not. The goal is harm reduction, quality of life, and patient engagement, not just to get off the medication as soon as possible. As you can see, 75% of those who were maintained on bup continued to engage in treatment a whole year after starting it, whereas 100% of the group that was weaned off of bup by 30 days had completely dropped out of the study within 2 months. This shows that chronic treatment works. This is the bottom line. It really is unethical to ask a patient to reveal a stigmatizing condition without any clear benefit. This is why this treatment for OUD is so exciting. A patient can check in suffering from acute opioid withdrawal. We can treat them right then and there in the ED with something that actually works, and then connect them with longer-term care. No one goes to the ED and pretends they have an opioid use disorder just to get a dose of bupe. Let's talk about the California Bridge program and what we are all about. This is a grant-funded program, and our goal is to help provide access to high-quality treatment of substance use disorders in all of California hospitals. We are so excited about the progress that has been made so far because each success traces back to an actual person who is getting better. Over the past year, we've touched a lot of lives. We've also made an impact on the healthcare system by building capacity to deliver high-quality MAT. As you can see, many patients have been identified and provided with effective treatment for opioid use disorder. Now that we have a framework on the value and effectiveness of MAT, moving forward, I would like to transition us into a discussion on practical nursing management of OUD. Now, we all took a course on therapeutic communication in nursing school, right? Well, our language and communication techniques are crucial. When we utilize discriminatory language, we actually create barriers to care. If they have felt bias or stigma in the past, people will avoid seeking life-saving health care solely based on prior negative experiences. People are more than their drug. We need to utilize language that reflects this. So how do we do this? Well, by avoiding terms like druggie, addict, and junkie. Instead, we need to use person-first language. Person who uses drugs, person with opioid use disorder. This is so important. The language we use affects not only how the patient perceives us and feels about their care, but it also impacts how our team approaches that patient and how we ourselves interact with them. So what exactly does opioid withdrawal look like? How can I, as a nurse, develop accurate assessment skills so that I don't miss it? Well, first off, the patient may just tell you. They might say that they are dope sick or kicking. Basically, it feels like the worst flu ever, including nausea, vomiting, diaphoresis, body aches, restlessness, tachycardia, just to name a few. Due to the discomfort of these symptoms, patients may be very irritable and impatient. Please do not discount them because you are not able to see most of their reported symptoms. If they say they are in withdrawal, they are. I also want to point out that this is not alcohol withdrawal. Unfortunately, some clinicians discount subjectively reported symptoms of opioid withdrawal on the basis of not seeing tremors or something similar. Now, what is the COWS scale anyway? The Clinical Opiate Withdrawal Scale is a tool that clinicians may utilize in order to identify and quantify the severity of opioid withdrawal. Some facilities may have the nurses calculate this score, while at others, the physician will. While a COWS score is not necessary to start someone on bupe, it can be a useful tool to recognize the common symptoms of withdrawal. I myself found this to be very helpful in my own practice when I first learned about opioid use disorder and withdrawal. It helped me to anticipate and assess the symptoms my patient may be experiencing and appropriately identify the opioid withdrawal. There has been much conversation about whether or not a COWS score is actually needed in order to appropriately initiate treatment. What we have found is that the patient self-report of how sick they feel is just as reliable as the COWS. It is not recommended to calculate serial COWS for dosing and redosing of buprenorphine or methadone, as this may become a barrier to care. Most important, trust your patient. In order to best treat our patients, ask them these questions. And they should be framed in the context of, I need to ask you a few questions because we don't want to make you feel worse, but want to help you get better. How sick do you feel? When was the last time you used? What did you use? Have you used methadone recently? As you have probably already deduced, these questions help to determine when the best time is to initiate treatment and avoid precipitated withdrawal. We really don't want to give bupe too early. This is the basic treatment algorithm that we use to start someone on bupe. We determine a patient is currently experiencing withdrawal. They get a dose of bupe, usually 8 milligrams. We wait about an hour and assess if symptoms have improved. This is our opportunity to stop and ensure there is not a different or additional condition that may be contributing to their symptoms. Most patients will be feeling much better. We give another 8 or 16 milligrams of bupe and link them to follow-up care. It is simple and straightforward, and it works. Of note, many patients have been on bupe in the past and may actually know what dose has worked for them, which is very helpful. The alternative option to the Quick Start algorithm is to discharge the patient with a prescription and instructions on how to start treatment later. This works best for patients who just used and are not yet experiencing withdrawal symptoms. Now let's move on to what is most important for nurses to consider when managing care for patients suffering from OUD. Decreasing stigma and discrimination. Even if a patient is not interested in treatment today, creating a culture of respect and promoting harm reduction keeps that door open. Patients who know that we treat them as a person and with respect will definitely be more likely to seek treatment in the future. This may save their life one day. We are advocates for our patients. I want you to be empowered by this knowledge and have the tools needed to drive best practice care. Educate, educate, educate. Patients want to know what to expect and how they will feel. Talk to them about it. Talk with your peers. I feel like my work family, and family at home for that matter, is probably tired of hearing me talk about MAT, but that's okay. We need to be talking about this. Lastly, follow the nursing process. Assess, collaborate with your team, plan care, implement best practice interventions, and evaluate their effectiveness. Then assist with making sure the patient has the prescriptions they need and good follow-up care. We have an incredible opportunity to be a part of something which is literally saving lives. Nurses are such a vital asset to the healthcare team, and we drive the care for our patients in a variety of capacities. Let's make sure we are giving our patients with substance use disorders the high-quality care that they need. Thank you very much for your time. If you have any comments or questions related to this topic, I welcome you to reach out to me at tana@bridgetotreatment.org. In addition, there are excellent resources that you can access at bridgetotreatment.org.